We are so happy to see everyone on the call. And yes, please go ahead and put your response to the icebreaker in the chat box, which was where are you joining us from today? Or what are you doing while you're listening to this call? And I think we're ready to begin. It is 12 noon, so welcome. Hello. Thank you for joining the monthly community meeting for Pulp Med Colorado. I'm Sing Pallett, the president. And today, Dr. Chris Horton is going to start us off as we get our speakers joining on. Chris, have you been watching who's on
Yes.
our? Oh, okay.
Good afternoon, everyone. I did see Chad Fear from the health department online. If he is ready to give us an update, Chad, that would be great.
Okay, great. Can you hear me?
Yes, sir.
All right. Just a couple things to kick us off here today. Um, Given the current partial government shutdown, we are following CMS survey guidance from the previous shutdown. So essentially, we will be doing IJ and non-IJ high level complaints and tries, and it's those that allege harm to an individual or individuals. We're able to write citations for surveys with IJ or harm findings, process deficiency lists, including those from surveys completed before February 1st, if there were any findings of harm or IJ on the survey, completing enforcement activities for those surveys, and being able to do revisits for surveys with harm or IJ to ensure no further harm to residents exists. I did want to bring to your attention as well that CMS updated, revised its guidance around special focus facility selection. And there was a revision in 2022 that provided that CMS would escalate enforcement actions, including termination for persistent noncompliance. Implementing a 3-year post-graduation monitoring with progressive enforcement for declining performance, and incorporating staffing data considerations into the facility selection process. Building on the 2022 update, CMS now has instructed states to consider a facility's prevalence for falls when selecting the special focus facility. And in Colorado, the percentage of long-term stay residents having a fall is above the national average. Colorado's at 49.4% versus the national average of 44.3%. So to bring to your attention, there's going to be a greater focus placed on the prevalence of falls. And we understand that, not all falls are a result of non-compliance, but it certainly is something that's going to receive more attention. And a reminder that special focus facilities will graduate from a program once it's had 2 consecutive standard health surveys with 12 or fewer deficiencies, cited at a scope and severity of E or less on the survey. Did want to bring also to your attention that recent immediate jeopardy situations have included wrong diet texture, increasing the likelihood of choking incidents, failure to provide sufficient supervision and devices to prevent choking during meals, failure to address repeated victimization by physical abuse of one resident by other residents, and a failure to offer the COVID-19 vaccination when available to residents. There was a recent outbreak which resulted in a hospitalization of at least one resident. Other frequent areas of concern have included serious facility-acquired avoidable pressure injuries, elopement, and significant medication errors involving life-saving medications. That's what I have for you today, unless perhaps Joe has anything she wants to add, or if there are any questions.
I don't think I have anything. Thanks, Chad.
Thanks, Joe.
And was that a correct comment in the chat box, Chad? Dr. Eager was just asking, what was that national average of falls? Dr. Burkan's caught 44%.
Yeah, Colorado's at 49.4 and the national average is 44.3. And I'm not sure if that's statistically relevant, but we are above that average, and certainly is something that, if it's been identified for the special focus facility consideration, it's something that will be on the radar, essentially at all, facilities.
Perfect. Thanks for that update, Chad. And I see Jenny Albertson is on with CHCA. If you'd like to give an update.
Absolutely. I am doing a couple of things here with this one today. I do want to give you somewhat of an update, but I want to kick it off with some information that I'm mostly going to send to you in the slides, not go through it all in detail because it's too much for the few-minute update here. But it was requested at our stakeholder meeting with CDPHE recently. Dr. Eber and I were chatting about this, that perhaps some of our medical directors don't know the differentiation between scopes of practice for each of the clinician types within our setting. So I've outlined it here for you. Under the RN jurisdiction in the nursing department, I think that's the primary area of confusion. And it is somewhat particular to Colorado, but generally this is going to be what you've experienced elsewhere. The pieces that are going to be most salient to your understanding as you're moving through your buildings is the limitation pieces, to understand why RNs or LPNs might need to have oversight for particular actions. LPNs particularly are, they struggle because they're often left somewhat alone on a unit, and when a fall does occur, say for example in Chad's illustrations, they are not allowed to do the post-fall full assessment when there's been a potential acute change. They are supposed to only assess in stable and predictable outcome situations. The other piece that has changed for LPNs that I think is important for all of us now and valuable, we no longer have to acquire a special IV authority for an LPN. They are expected to go through that in their LPN education. And LPNs are authorized in Colorado to be administration and management in the nursing department. On the RN side, the only real limitation is prescribing and selecting medication. The assessment is deferred to them, and they are supposed to monitor and report back on treatment plans. It's a significant part of their role. I added the CNA Med information here for you to see kind of why communities might utilize CNA Med techs versus not. And these are the most common elements that I've heard outlined. One is that if a medication passes too onerous and so forth, RNs really benefit from having someone just do the regular med pass. Of course, again, they can't assess for efficacy of the medication, so there is a limit to what they can administer. And then the disadvantages of it pulls a CNA off the floor when you need them to do day-to-day care. But I've had this be really successful in my communities, and I do recommend putting people through these programs. CNAs do have a limitation that often gets exceeded, and that is the ability to titrate oxygen administration. They are supposed to be particularly trained for oxygen administration at all. It's not part of their basic training. They have to be competencied on oxygen. And all those other pieces listed in the bottom green box are also considered additional education pieces that they're not allowed to do without specialized competencies. And then I outline this for your reference when you have volunteers in the building and NAs that are not yet licensed or certified as CNAs. They do have several things they can and cannot do. Sometimes, again, you'll see people exceeding their training, particularly when it comes to like resident transfers, helping people with their garments, etc. They're technically not supposed to do that level of personal care. Quick note, up to date, you may have already been made aware of this, but they have changed the up to date definition. from NHSN reporting. And the reason why this is of particular interest, besides from a clinical standpoint, is it now brings us into a uniform definition, and it allows us to report it on our MDSs appropriately, finally, as to whether people are truly up to date. We were kind of throwing something in there before. And there are some legislation elements being proposed. They're not really fully presented on the floor yet, but this week we will start seeing that. One of those is going to be a medical marijuana bill for hospice patients. We don't anticipate that going anywhere in the SNF setting. There is some talk about adding injectables to a CNA's authority. Speaking of scope of practice, and particularly trying to allow insulin administration in ALRs from QMAPs, although QMAPs are not technically in the bill yet, so we'll see. It would really only apply if they use a CNA med in an assisted living setting, which is not typical. The biggest piece on our radar is a memory care bill, which requires us to report information as to what we're truly advertising for memory care in assisted living and SNF settings. And then Chad may have mentioned this, I got on a minute late. CMP funds, it looks like we're going to be able to spend those toward workforce. And I think I may have mentioned that to many of you before. Here's our top 10 citations for 2025 for your reference. Falls is number 2, if that it incorporates falls. There's a lot of other things that go into that tag besides falls. And then our upcoming events in education.
Thank you.
Great. Thank you, Jenny. Does anyone have any questions? I think I'm going to turn it over to Dr. Pallett, who will introduce our next speaker.
Very glad to. Yes, our next presentation is on heart failure, the guidelines, the latest considerations with older adults. And I'm very pleased to introduce Dr. Michael Horne. He is a cardiology nurse practitioner and assistant professor at the University of Colorado College of Nursing. He is board certified in adult and geriatric populations and has an additional cardiovascular knowledge certification, that's what the CCK is after his name, from the American College of Cardiology. He was also inducted as an associate of the ACC in 2025. Congratulations, Dr. Horne, and thank you for joining us today.
Thank you. Well, thank you. Thank you for having me. You hear me okay?
Yes.
Great. Well, I'm going to share my screen. We practiced this earlier, so we should be in good shape, but let's just make sure everything shows up here. Let's see. With teaching online as much as I do, I should be good at this. So, all right. Is it showing up okay there, Sing?
Yes, we can
Great.
see
Okay.
it.
We'll go ahead and go into slideshow mode here. Well, thank you again for having me today. As you mentioned, we're going to talk a little bit about heart failure. I'll talk about the agenda in a minute. And thank you for the nice introduction. I certainly appreciate that. This is actually not my picture because the nice guy has dark black hair. I decided I like this image better. So we're going to go with this one versus my normal gray. So my assumption is that a lot of people, or most people on the call, have a reasonable familiarity with heart failure. So I'm not going to go, through a lot of what is it, right? If you do have interest in that, or for your staffs, I have 2 additional lectures, and they are pre-recorded as well as PowerPoint. One that goes through the patho of heart failure and the etiology a pretty good bit. One that goes through the medications. They're both about an hour each, and I'm happy to share those. Anybody that wants them, you can take them. You can modify them even. I'm very open about my intent is just to get information out. But today, we're going to specifically do a real brief background, brief review of background heart failure guidelines, and then look at the latest. So the change since the quote new heart failure guidelines, which were 2022, so they're not quite new anymore. Then look at some considerations for older patients in long-term care and a few summary thoughts. I'm going to go through this pretty quickly. I do have some things in the agenda as well that you can have kind of more for future reference also. So first of all, why is this important? Well, we know this, but there's a lot of heart failure out there, right? There's a lot of new incidents each year. There's a lot of prevalence out there, 8 million plus by 2030. It is also very expensive, mainly through a driver of readmission, which is obviously a big focus for all of us, both for the patient benefit as well as the cost benefit in managing healthcare. And relevant to this group, heart failure is much more prevalent with age. And so this chart actually shows that, and you can see that there's, at least linear, almost maybe somewhat of an exponential curve of heart failure prevalence and age. And this is across general population. I don't have the specific number for people, say, in long-term care, SNF, or rehab, but it would even be higher. So certainly it is a issue that is prevalent with aging. The other big issue about this is the prognosis. So what this chart shows, the gray or tan line there shows average years to death based on certain ages, right? So obviously it's fairly long, even in most cases, even down to 80, 84. The other three bars are types of heart failure based on LVEF, which we'll talk about in a minute. And as you can see, it is a huge difference. Obviously, the difference between years of expected death for someone who doesn't have some type of heart failure and the years for someone who does is a dramatic difference. Now, the good news is we can make a difference in that, right? So what this study showed, and this one's a couple years old, this came out around the time the new guidelines. What it was comparing was for someone with HFrEF, which is the one we'll talk about in a minute that has the most treatment as far as medical pillars, medications. This was comparing, quote, conventional treatment before the new guidelines, which was primarily a beta blocker and an ACE or an ARB, with treatment adding in Entresto, sacubitril, valsartan, ARB and neprilysin inhibitor, and an SGLT2, which are now the four pillar drugs, of course. And what it showed, and this was an analysis. It was a combination of looking at individual trials for each of those new drugs and aggregating it. And it showed an additional potential 6.3 years of life for someone who was able to be on all four drugs at close to the target doses. Now, again, it's a calculation, but let's say it's half off. Let's say it's only a quarter right. That's a year and a half extra, right? And I'll tell you now, as someone who has a 4-year-old grandson, an extra year and a half for the grandkids, a big deal, right? So it is important. Recognize that, getting there is a challenge. And that's what we see when we look at real data. So what this is showing, and that pink line that's on the top of the bar charts, is people who are not treated with the four pillar meds, in this case for HFrEF, and SGLT2 is actually not even on here, but didn't also have a contraindication. So a lot of times they're not treated, and certainly in our long-term care and SNF facilities, they're not treated with some of the guideline-directed heart failure medicines because their blood pressure gets too low. There's other issues in doing it. This particular chart actually was showing that there was really no known comorbidity, and there's still a pretty good chunk of people who are not getting the benefit of guideline-directed medical therapy. So why is that? Well, as C. Everett Koop once said, right? Drugs don't work in patients who don't take them. So that's the bulk of the reason. But why is that the case? Well, there is some cost consideration. Now, when these guidelines first came out, Entresto was still a brand name. It's generic now, so that helps, but it's still a higher tier. The SGLT2 inhibitors, except for dapagliflozin, are still brand name. So that's certainly a driver here. A bigger effect, and certainly in a long-term care setting, are side effects. All of these medicines will reduce blood pressure to some degree. That can be a challenge. We heard the comment about falls earlier, right? So, and that's certainly not the only thing that drives falls, but it's something we have to consider. And then finally, this has changed more. This provider knowledge, I think, has gotten a lot better now that the new guidelines have been out for a while. But there's still, I think, some of that, and that's why I love doing these presentations. And a little bit of inertia, right? And I think sometimes, and I'm not blaming us because I say me as well, right? I practice doing cardio consults and long-term care now a lot. We are maybe more reluctant than we should be to be a little more aggressive with heart failure treatment and long-term care. There certainly are absolutely reasons why you shouldn't be, in particular patients you shouldn't be. But generically across the whole group, I think we need to be careful not to just, well, they're in long-term care, we don't need to titrate up these meds, because they may actually be people who do benefit and don't have any reason, not to. So let's review yes, I'm sorry. Okay, thought I heard something. Let's review real quickly the heart failure classifications, because this is how the guidelines are set up. This is how the studies were categorized in terms of the population groups that drove the guidelines. So there's really three. Stage from ACC is stage A, B, C, D. Functional ability from New York Heart Association is class 1 through 4. And LVEF is based on the left ventricular ejection fraction. That's the one that really drives most of the guidelines, with stage and functional ability being sort of ancillary things that are rolled in to some of the guidelines. But a lot of the studies were categorized by LVEF in terms of their populations they were comparing, and thus that research is what drove the guidelines. So we look at LVEF just to make sure everybody's clear. The first two have been around a while, right? HFrEF and HFpEF. LVEF less than or equal to 40%, LVEF greater than or equal to 50%. And then the two new ones that came out when the guidelines came out, HFmREF, so kind of in the middle, and then HF improved EF. So someone who'd had HFrEF, we got them on guideline directed medical therapy and it got better. They defined this one because there needed to be some studies to say, okay, well, now that they're better, do we keep them on the same medicines or not? And the answer is yes, but there needed to be kind of a categorization for that. So the other final thing I put in the background, and this is just something that I think we've gotten better at as well. ICD coding doesn't make it any easier because there's not coding for HFrEF and HFpEF. But remember that these classifications, whether it's ACC stage, whether it's New York Heart Association functional class, or LVEF, are classifications of what's happening in that heart failure, whether it's by LVEF, whether it's by functionability, whether it's by structural changes. They're not the etiology. The etiology of heart failure is either left-sided, right-sided, systolic, or diastolic, and factors that led up to that. So I really encourage people not to mix and match because I think there's sometimes there's a little bit of an association of, well, they have HFrEF, so they have left-sided systolic heart failure. Well, yeah, likely they do. That's why their ejection fraction is reduced. But recognize you can have within HFrEF on the LVEF classification, you can still have also right-sided heart failure and diastolic heart failure. So I think it's important to not mix and match. One's a classification scheme, typically used for guidelines. One's an etiology, and they imply different things. Let's look now at the guidelines, and then we're going to look at some updates since. So just a quick review. When you look at the guidelines, they were broken down by ACC stage and by LVEF. So for stage 1 and stage A and stage B, stage A is basically a person that has risk factors for heart failure, but no symptoms and no structural indications if you did an echo. No volume overload either. Then stage B, they still have no symptoms, but they do have some structural issues if you do an echo or some other metrics to look at things. The big message on both of these is prevention, right? So we want to prevent them from going to stage C that we'll talk about in a minute. And so if they have diabetes, we want to treat their diabetes. Specifically, we want to, if we can, treat it with an SGLT2 inhibitor as well as other medicines, whatever we need to control their blood sugar. We want to control their blood pressure. We want to do the things that prevent them from going forward. At stage B, there's a few other considerations we do have for some reason an echo that shows significant LVEF reduction. We may actually add some of the pillar medicines sooner than waiting to stage C. Stage C then, which is HFrEF, and I'll talk about HFpEF in a minute, is really where the bulk of the medication focus has been. And there's 4 pillar meds for someone that is in stage C and that has reduced ejection, HFrEF, reduced ejection fraction less than 40%. And that is either an ACE or ARB, or preferably an ARNI, Entresto, but if you can't do that for some reason, an ACE or an ARB, a beta blocker, one of the 3, so metoprolol, succinate, bisoprolol, or carvedilol, mineralocorticoid receptor antagonist like spironolactone or Clarinone, SGLT2 inhibitor, dapagliflozin, empagliflozin, and diuretics if needed, right? They're not one of the pillar treatments. If you don't volume overload, you don't need any diuretics. For someone with new heart failure, we get them started on those meds, get them titrated up as high as we can to the target doses, and about 2 or 3 months later, we measure the LVEF again. If it's improved, great. We keep them on the medications. If it's not, we look at other considerations. So if it's an African-American person, we might consider hydralazine and a long-acting nitrate, like isocitrate mononitrate or dinitrate. If they have significant LV reduction and or if they have left bundle branch blocks, sometimes an inflammable cardiac defibrillator makes sense, or cardiac resynchronization therapy. What happens with the CRT, it's just a fancy kind of ICD, and it has biventricular pacing, so it has leads in both ventricles, and it synchronizes them. Because when we have left bundle branch block, in left case, the left ventricle squeezes ever so slightly later than the right, and that dyssynchrony can reduce cardiac output. Not a big deal for people that have normal output, but if you have reduced output already, significantly reduced, that little difference in synchronization can make a big difference. And then if none of those are really getting us where we need to, we're kind of in refractory heart failure, and now we're looking at, palliative care in a lot of cases, which we have in long-term care, and then sometimes, obviously, potential transplant or potential assist devices. Now, if we look at, and I'm not going to spend a lot of time on this one because this got updated since the guidelines, but what we saw both for HFpEF and HFmrEF, so basically any left ventricular ejection fraction above 40%, is that SGLT2 inhibitors have the most evidence available to this point. It was still 2A at that point versus 1A recommendation, but there. And then a little bit also for some of the other pillar meds with the exception of beta blockers. But I'm going to talk about an updated slide about this in just a minute. And then I throw this on there just for some other awareness. I don't see a lot of these used. I certainly don't see a lot of these used necessarily in long-term care, but they might be and they could be applicable. Ivabradine is a medicine that if someone's on a beta blocker for their heart treatment, or if they can't be and they're still having a pulse rate that's too high, say above 100 on average, that can reduce cardiac output. And so ivabradine can reduce heart rate without reducing cardiac entropy. So it's not a beta blocker. Versaquat is a kind of unique medicine that is used for people that have had multiple heart failure admissions, and especially with volume overload, they're on IV diuretics. It has been shown to reduce that. It is still brand name, so there is a cost issue there. I only put digoxin on here to say don't use it. and let me qualify. If you got somebody that's been on it a while, that's doing well, especially it's more palliative care, it's helping their symptoms, okay. I'll tell you, as far as new heart failure patients or even titrating up stuff, we almost never, ever, 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 ever add it. It can sometimes help with symptoms. It does not help with mortality, and digoxin has a lot of issues. We do use it for rate control and AFib a decent amount still, but not for heart failure. So just some other things that you might see out there. All right, let's talk about the latest. So that's where we were in 2022. So heart failure with preserved ejection fraction got updated. Recognize that 50% of all the new heart failure cases diagnosed are heart failure with preserved ejection fraction, not FREF. So it's important we have those. And prior to really, 4 or 5 years ago, we basically treated that with diuretics, which is still a treatment. So if somebody's volume overloaded, we need to treat that. You have to be careful if it's right side heart failure, not to overtreat, but in any event we do. But we now have a medicine, the SGLT2 inhibitors, different ones, that do have some proven benefit. And for pretty much all people with HFpEF, if they can tolerate it, the guidelines are to start it. I do see a lot more of this used in long-term care, both in HFrEF and HFpEF, and I'm delighted to see that over the last year or two. In addition, then, if they're pretty much all women, and then certain men in terms of based on their EF, a mineralocorticoid receptor antagonist, and we'll talk about finerenone in just a minute, but one of them, and an ACE and ARNI and ARB are both potentially appropriate. So let's talk about GLP-1 receptor agonists first, right? Because they do everything, right? We're just going to put them in the water and we're all going to be healthy. So obviously they were initially around for diabetes. They're huge in the weight loss arena, and they have a bunch of other approvals around kidney disease. There's other studies going on for even pancreatic cancer, pancreatitis. There's a lot of stuff that's going on, but let's look specifically at heart failure. So, first of all, there are no FDA-approved uses yet. However, for heart failure preserved ejection fraction, especially with somebody that has obesity and diabetes, there's a couple trials, and I've got some details in the appendices that talk about the benefits. And there were definitely benefits in reduced heart failure events with GLP-1 receptor agonists in HFpEF with obesity and diabetes. On the flip side, not such the case is not there for HFrEF. There really hasn't been any clear benefit in the studies that showed up. And you obviously know before already, they are certainly approved for diabetes treatment for people that have prior cardiac events. So that was there. So what I would say in HFpEF is if you've got someone, especially that has another need for a GLP-1, it can be a really nice additive treatment for HFpEF that does have proven benefit. And in, most cases, these medicines are pretty well tolerated. How about finerenone? So finerenone is a non-steroidal mineralocorticoid receptor antagonist, like spironolactone is steroidal. There's a couple trials. The biggest one was Fahrenheit's trial. that showed for non-HFrEF, so either HFpEF or HF improved ref, LVEF over 40%, that there was a pretty substantial improvement in the endpoints of cardiovascular death and total heart failure events with the use of that. The other thing that's kind of cool about finerenone is, unlike spironolactone, there's less hyperkalemia. It doesn't stimulate androgen receptors, so there's no gynecomastia, impotence, menstrual irregularities. It has a milder BP effect because, as you know, spironolactone sometimes this can be a good thing if you're trying to reduce blood pressure, but spironolactone can be a pretty strong blood pressure medicine, and minimal diuresis. Now, the less hyperkalemia, if you're using spironolactone to counteract hypokalemia from Lasix, then maybe that's not as helpful. But for people that's more of a concern, be aware that it does that. It is not a substitute for spironolactone or eplerenone for HFrEF. This is a HFpEF or HFmrEF drug at this point. And the issue is, there's a cost issue here. Like everything, that'll get better eventually, but right now it's a pretty high tier. But again, it's something that definitely can be considered because it has good data based on it. All right, let's talk about older adults and older and long-term care, but older in general. So this person obviously has got some bilateral lower edema, and I'm going to claim it's from a heart-related issue because I also see some jugular venous distension there. By the way, that's a great way before you even order a BNP. If you see someone with bilateral lower edema, is it from incompetent veins or is it from a heart issue? Well, if they've got jugular venous distension, that's going to point more toward at least the heart issue being a contributor to it. So I still encourage that assessment. An old cardiologist taught me that a long time ago and drilled it into me along with a bunch of other things. And I still think it's a good idea. So what about older adults or community adults? We first of all know that there are not a lot of guidelines, right? It's getting better. We even have, on a separate note, we even have a trial going on right now that is looking at starting statins in people that are over 75. We know that continuing statins over 75 helps somebody with secondary prevention, but we haven't had a lot of data on primary, so we may have that. But in general, that there's a lack. So what do guidelines that we do have say currently? There is a HFpEF predominance. So even though it's 50-50 in the general population, it's higher in older or community-driven people. There's certainly a lot of multiple morbidity you got to consider. There's a lot of polypharmacy. We know how many drugs a lot of our members take. And there's certainly a lot of risk of falls, and we heard continuing concerns about that as well as potential, bigger renal functions as kidney function goes down. So the message from the guidelines, though, is first, still, yes, guideline-directed medical therapy. There is certainly benefit in whatever age, typically in that. The difference is that we've got to be more careful in monitoring, and we want to start low and go slow. So I've shown you in the appendix the typical starting doses and target doses of the pillar medicines for heart therapy. Recognize you're going to start on the lower end of those, and you're going to titrate slower, and you probably, in many cases, will not get to the top of those because you got to be concerned about blood pressure, potential related falls, just blood pressure in general, symptoms, renal issues, electrolyte issues, etc. Certainly, we want to look at the overall patient, right? All these, especially most of our patients in long-term care, they're very heterogeneous, right, in terms of heart failure. So there's not a one-size-fits-all. Obviously, chronologic age and biologic age, we already know this are different, right? We certainly can have a 65-year-old who is in worse shape than our 90-year-old people, and vice versa. And I do certainly look at palliative care. But the bottom line here is just always remember, though, that age alone, right, or even being in a long-term care facility is not a contraindication to the 4 pillar drugs, say, for HFrEF. It is something you have to consider, but it's not a blanket that they won't benefit, because some of them certainly will. So let's look at HFpEF and HFrEF separately for older. So HFpEF, there's no medication that clearly reduces mortality. You've got to be aware of that. There are 2 medicines now, SGLT2 inhibitors and finerenone, that can improve symptoms and reduce hospitalizations and heart failure events. Certainly, maintaining volume with diuretics helps that as well. We want to maintain blood pressure, but we have to be careful on the targets. If the person has AFib, and I have a quick case on this at the end, and their rate is not controlled, that's something that's an opportunity, because a rate that's running too high will reduce cardiac output, and that's something that potentially can be addressed. Certainly weight, diabetes, sleep apnea, chronic kidney disease, and we got to look at all the drugs they're taking. And then note on here, we'll see what happens with the GLP or receptor antagonists. They're a consideration now, but whether or not they get FDA approved in a guideline, I'm not sure. For HFrEF, it's really the same thing as it is for young people, with the exception of you got to be careful about all the side effects and all the things that can occur from all the pill meds. But if you can get them on them, great. Do, right? I mean, if this is somebody's got 3 months to live, not as much of an issue. But it's somebody that's in there that's younger, that's maybe in there for mental issues, not dementia. They may benefit tremendously if they have some heart failure issues. All right, let's finish off with a few cases. And I think we're doing pretty good on time here. Yeah, good. So I'm looking at long-term care, and these are actually cases from me. These are real life cases. 77-year-old female in long-term care due to mild dementia, MI, resulting HFrEF 2 years ago. Mild, very mild dementia, actually. Has peripheral artery disease, former heavy smoker. She's currently on 50 milligrams of metoprolol succinate, 40 milligrams of Lasix, aspirin, potassium supplement, probably because of the Lasix, and a statin. So she's not on, even though she has HFrEF, she's only on really one of the medications for it. And she does have plenty of blood pressure room. Vital signs are normal. Fortunately, her kidney function is also normal at this point. She's actually been doing okay. This person, when you talk to her, love this lady there. She does not complain. I think if you cut her foot off, she wouldn't complain, right? So she's not one that's raising a lot of issues, which sometimes can be a problem, right? She's not the squeaky wheel. But she has noted a little decrease in energy, and there has been a 15-pound weight gain in 2 months, and she does have edema, and she's not overweight. So it's very determined it's edema, not weight. When you talk to her about it, she says, well, I just think I've been eating better. The food here is pretty good. She hasn't really had a lot of focus from the providers, kind of because she's generally doing okay, other than this weight increase recently. But because of that, they did increase the Lasix from 40 milligrams a day to 60. So we kind of got involved, or I kind of got involved after that, and it was because of the fact we were having some minimal effects. We didn't really get any benefit from the Lasix increase. Her original echo, by the way, I know she had HFrEF, was LV for 20%, which is obviously low. We did do a repeat. We wanted to see what was going on. It had gone down a little bit to 15%, which is, of course, even lower. And her BNP was pretty elevated. I didn't have a baseline. So, you really need a baseline for BNP to be real meaningful, but it was elevated. So it was certainly elevated. And there's some consideration of hospice at this point based on that. Our thought was that maybe we've got a volume overload case here that we could treat a little more aggressively, and that might do some really help. So increase, first of all, Lasix to 40 milligram BID. Recognize, I know that BID diuretic dosing can be a challenge sometimes in long-term care, but if you have somebody that's not getting the benefit of increases on QD, BID can make a huge difference. The other thing you can do, and this is not a huge Lasix dose at all, but if other options are to go to Bumex or torsemide, because those are both much better absorbed in the GI system, and they will produce much more consistent results. And sometimes people just get to a point they just don't get results from Lasix. So, 40 of Lasix is a milligram of Bumex and 20 of torsemide. Also started her on ACE inhibitor because she needed to be on that. Do you ever use Lasix, subcutaneous Lasix? I actually haven't used Lasix, sorry, that. We do have some places now, not necessarily where they can do some infusions for IV Lasix, but I haven't used the sub-Q. I'd be interested to, I'm going to do a little study on that and see what kind of results they're seeing from that. It's a good question. Since we increased the Lasix and ordered the ACE, obviously we did labs appropriately. So 2 weeks later, her weight was down 10 pounds, energy improved, minimal bilateral lower edema, systolic blood pressure still good, 130s. BNP was reduced. That's probably more baseline. BNP stable. And we went ahead and added an SGLT2 inhibitor. Again, we're kind of titrating her up on our heart failure, HFrEF medicines. But this was a pretty dramatic improvement. 4 weeks later, the weight is basically stable. It's a systolic blood pressure, maybe a hair less. We've added some things to it, obviously. Significant symptom improvement. And now I'm titrating the meds. Now, I should probably have added spironolactone first here versus titrating the metoprolol, but either way. And then we'll continue titration as possible with her. So this is a person who the thought was kind of, well, based on her heart failure, there's not a lot we can do. And her real issue was, number one, she was volume overloaded, and then she wasn't on some of the meds. And she was a type of person, blood pressure-wise, and kidney-wise, that we could do this, right? We could add these meds and we can titrate them up. So this is an example of one where we got to make sure that we look and for people we can do it. Recognizing there's plenty that we can't, right? And we don't want to make that fall number we talked about worse. Second quick case, last case, tachymeopathy. I put this in here because this is sometimes something that's relatively easy to fix that sometimes can be missed. So we've got an 8-year-old who was diagnosed with HFrEF based on her echo, which showed LVEF of 35 to 40%. But the consideration was, is this really a cardiomyopathy or is this tachy-induced myopathy? And the reason for that was because she had persistent AFib and just based on vital sign data, we knew the rate wasn't well controlled. She was on pretty good meds across as far as for the HFrEF. She wasn't on the SGLT2 inhibitor, but otherwise. And, we wanted to see what we could do here. So we updated the metoprolol, succinate from 50 to 100, did a follow-up Holter to see where we were. Her average heart rate was 95, which for an 81-year-old person is not a problem. It can be less than 100 under AFib rate control. But below 80 is even better. And since we knew she was having some reduced cardiac output, there was the thought that certainly could be a contributor. And she was having some symptoms with it as well. And so we needed to see if we could help. So we increased the metoprolol to 200 milligrams, so succinate QD. You can go as high as 400, maybe not with some older people, but you can. But we increased her to 200, and then we scheduled a follow-up echo for a month to assess. When we did that, things got magically better, right? And I say magically, I've had several of these happen, typically with younger people, but it can happen. This was a tachy-induced reduced cardiac output, not a traditional heart failure. So we got that. We didn't make any changes at that point. We were delighted. She was feeling better. We did do a repeat Holter to kind of verify what we were at, and we had brought the average heart rate down from 95 to 85, which was much, much improved. And then the only thing we did the last time, because she's basically kind of in, HFpEF or HFmrEF, is we had the SGLT2 inhibitor and, of course, the appropriate follow-up labs. So another example of where we can do something that wasn't that challenging to do. So a few summaries here. You all know this, but for your staff, and just as a good reminder, because I still see it missed sometimes, if you're going to stop, adjust a diuretic or an ACE inhibitor, an ARB, or Entresto, because that has ARB in it, or melanocortin receptor antagonist, make sure you check the potassium and serum creatinine, right? Do a BMP or whatever you're going to do. If you're starting an SGLT2 inhibitor, you want to check a BMP as well, and either some A1C or some type of more frequent, if you need to, blood sugar monitoring. Now, SGLT2s are great in that, if you don't have high blood glucose, they're typically not going to reduce it much. The way they act is a smart drug, right? They increase or increase expulsion basically in the kidney of blood sugar if it's too high, but they don't if it's not too high. All of our long-term care patients are, they're unique, right? So we got to really roll in their factors and see what is right. But I really want to be careful about not either saying, yep, blanket them all with aggressive treatment or blanket none of them with aggressive treatment, right? Because there's some that are in the mix of that. If you can, for heart failure med titration, try to preserve some blood pressure room. So if they're on a medicine that reduces blood pressure, that maybe they don't need to be on anymore, or maybe they can be reduced. Good for reducing polypharmacy anyway, right? Consider that. Try to get a full mix of guideline-directed medical therapy and then titrate each. So what that means is if it's a HFrEF patient, we'd optimally like to get them on a beta blocker, ACE inhibitor, ARB, or Entresto, SGLT2 inhibitor, melanocortin receptor antagonist, all four first before we start going up on any of the four. The research shows that is more helpful than stronger doses of any particular one medicine. Now, there's some times you can't do that, right? If you have a heart rate issue and you need to increase your beta blocker first more, that you do. But in general, that statement. And then certainly, titrate based on patient situation. That's my presentation. In the appendices, there are the drug levels in terms of what you start, what you're trying to target. There's a little more on the GLP-1 receptor agonist, the method of action for the drugs, which might be something helpful for your staff units and how these drugs actually work in heart failure. Summary of the older adults, and then a couple more cases related to some aggressive treatment and some oncology changes. And there's the references. Certainly, anytime, I'll take some questions now too, but if I can be of help, let me know. See, I got a question to comment. For I remember, ablation for AFib indicated for HFrEF with AFib. It seemed like it'd be better to start. Yeah, so the AFib guidelines, of course, got updated last year, and there definitely is a more aggressive push for rate rhythm control for people with heart failure. Now, I would tend to agree that I probably would still start global elected, guidelines elected medical therapy and do the 3 months assessment and see where I am. Because if I solve it that way, I've solved it. But if not, then there's a pretty aggressive stance now on either ablation first, actually, even more so than rhythm control meds, because rhythm control meds have a whole lot of, complexity. But ablation to fix the AFib, or take them out of AFib for people with HFrEF, because that dysynchrony from the AFib in terms of the lack of atrial kick can be enough of a difference in cardiac output for someone that has significant heart failure. Doesn't necessarily affect other people with AFib as much, but it can be. So yes, that is definitely something in consideration, but I also agree with your point. How much are you using Entresto, and what is the rule of loop? Entresto, much more so now than we had in the past because it's generic. The only thing you have to be careful about Entresto is it typically, for most people, is a stronger blood pressure medicine. It will reduce blood pressure more. So if you've got somebody that's, even if they're asymptomatic and they're running in the, I'll say 90s, and you'll throw darts at me for long-term care, but let's say they're running in the hundreds systolic and they're asymptomatic, they're okay. But that might be the person that might be better on an ACE or an ARB.
Oh, Michael, I think we just lost your sound.
You able to hear me?
Oh, yes, I can hear you. Unless it was
Okay,
just
I have no clue. So so I was answering the Entresto. Did you hear most of that?
Yes, and I think you were
Okay,
going to
then
address the loop diuretic.
okay, yeah, and for the loop diuretics, again, it's really only if needed. I mean, they're not one of the full four-pillar treatments. So you have somebody that's not volume overloaded, you don't need to give them a loop diuretic. Now, a lot of these people are. So they're lower in priority, right? Unless they're volume overloaded. And so if you don't have to use those or use them less to create some blood pressure room, because they will temporarily reduce blood pressure, that you can then use like Entresto, that's great. The one comment I'll make on loop diuretics and diuretics and well is that, most of us, and I think it's not a bad practice at all, when somebody gets volume overloaded, let's say they're normally on 40 milligrams of Lasix a day, or one of Bumix, whatever it is, we'll do a burst of 3 days, maybe going from 40 to 60 or even 40 to 80, appropriately adjust potassium supplements we need to, or whatever, and then drop them back, see if that fixes it. I think that's a good strategy because it doesn't stress the kidney that long. If you have to do that, though, 3 or 4 times a month, it's time to go ahead to the next higher dose ongoing of your diuretic, assuming that they can tolerate it. Obviously, if you get into some cardiorenal issues, now you're getting into more potential end-of-life stuff and IV diuretics, which are challenging to do in an outpatient environment. But yeah, good question. Did I answer it, David? Hopefully.
Someone else was asking, what is the definition for tachymyopathy? I hadn't heard that term either, although I think I
So
understood the concept.
yeah, good comment. It's really cardiomyopathy, and I associated it with heart failure in this case, reduced ejection fraction, that is caused by tachycardia. In this case, the tachycardia was from rapid ventricular rate response, RVR, from the AFib, right? But recognize, when the heart beats faster to a certain extent, there is not enough time for the filling and then expulsion of the blood, and so cardiac output is reduced at some point with tachycardia, and I had, like I say, most of mine were younger when I was practicing in the clinic in the hospital with Kaiser, but I would have, gosh, probably one a month or more of those type of patients who we could quote fix just by fixing the rate. Yeah.
Another question I've been asked is the evidence-based beta blockers. There's some physiologic reason why, like metoprolol succinate is on that list, metoprolol tartrate isn't. Should we make an effort to switch people?
If we lost him, I can answer that. The
Okay.
reason,
Okay, thank you. Yeah, I thought maybe it was on my end.
yeah,
Okay, you got me back now.
Oh, yes.
Okay, so yeah, metoprolol succinate was in the study, as was carvedilol and bisoprolol for heart failure improvement. There is no really physiologic reason to assume that other beta blockers wouldn't provide the same benefit if they were in that one study. So we always use metoprolol, succinate, carvedilol, or bisoprolol. I actually use a decent amount of bisoprolol because it's non-lipophilic and it typically doesn't cause as many side effects as, say, metoprolol. I would have somebody on metoprolol with fatigue, other just not feeling so great, and I would change them to bisoprolol. Maybe it was placebo effect, but me telling them that I've had patients that it helped. But literally almost every one that I went from metoprolol to bisoprolol had less symptoms, and they're both approved. So, and they're both generic and all that. So. And they hit the same receptors. Carvedilol obviously is also going to hit the alpha-1 receptor, so it's going to reduce blood pressure more. But the others, metoprolol and bisoprolol, are similar.
There's a question in the chat box about side effects of spironolactone. Would you continue it if it required potassium binders?
Yeah, that's a good question. I might try to do a couple things. If there's no other way to fix it, and I'm continuing to have the potassium problem, I would probably either first reduce it or totally stop it unless it's a person that we feel like spironolactone is key, then you could use the potassium binder. But the other thing you could do, let's say that they are running a little volume overloaded, make sure you're using at least as much as you need of the loop diuretic because that'll reduce the potassium some. Yeah, sometimes you may have to, right? Now, it'll be interesting if that's a HFrEF person, there's not as much of a choice. If it's a HFpEF person, the finerenone certainly could be a potential there because that's going to cause less hyperkalemia. It'll be interesting to see how that one rolls out. It's kind of like colchicine with CAD. We'll see how much it starts getting used.
Thank you for answering our questions, and we appreciate this presentation.
Sure, absolutely. Thank you for having me. And I said, anytime I can be help, I love talking about this stuff. I'm a cardio nerd for sure. So I'm happy to help.
Thank you. And we should, Dr. Horne will be coming back later this year to talk about lipid management. Is that what we decided?
Yes, yeah, because we're going to have new lipid guidelines coming out, I would imagine in March. I'm aware of a little bit of a preview copy of that. And so we'll have some fun things about there coming out with that as well.
Look forward to it. Thank you so much.
Thank you all. Thanks for the comments.
Appreciate the engagement from everyone on this call. And we will wrap up today with some announcements from our organization. And Dr. Leslie Eber, if you are available, I'd love to hear what you are looking forward to on Grand Rounds from University of Colorado this Thursday morning at 7:30 a.m.
Oh, thank you so much. Well, Grand Rounds at CU is going to be really a great opportunity. Paige Hector is going to be presenting about nonviolent communication, which always kind of throws me that an acronym, but she's wonderful. She'll talk about communication in post-acute and long-term care with patients and families and staff. And so really just want to encourage everybody. Paige Hector is not often in Colorado, so this is an incredible opportunity to see her in person. And CU Geriatrics Department actually extended it to everybody, our whole community. It's going to be from 7:30 to 9, and you can join virtually through CU. And I know that Singh has shared the poster so you know how to join virtually or come in person. So thanks.
Thank you. I look forward to it too. The following week, on Friday, February 13th, we have a small work group meeting in the morning talking about medical director qualifications. If you'd like the Zoom invitation to that, please let me know. And also on Friday the 13th, we are going to have our journal club. This will be on a Friday instead of a Thursday this month. We're trying something different. And maybe in March, we'll try yet something different. You'll have to stay on your toes and watch for the announcements. But we're trying to get to a journal club that we can have consistently and can provide the clinical information that our providers need. Friday, February 20th, we'll have our public policy discussion. And that's important because this year, if you are a member of PALT Med, of the national organization, you can vote for the national leaders. That's a change compared to previous years. And so we're going to have a little meeting for people who want to learn a little bit more about the candidates and the issues before you cast your vote. We're going to continue to have the monthly meetings like we are having today. And all this leading up to our Friday, April 24th annual conference. Don't forget to register. I can share the agenda with you to get you excited, but this is going to be our annual conference, which is available either in person or this year, you can even attend it online. Let me just pop up the agenda while we're talking and can see that there's some fabulous topics and fabulous presenters who will be there. I hope I can keep sharing it. So this will be in Denver. It's Friday, April 24th from 7:30 in the morning until 4:30 in the afternoon. You can come in person, you can come online, you could split up your day, whatever works for you is fine with us. And in our upcoming meetings, we'll probably highlight some of these topics and speakers. Today, I'd like to highlight our keynote presentation. Dr. Leslie Eber will be talking about connection, capacity, and context, improving our communication in post-acute and long-term care. And she's shared that especially in situations where there's uncertainty in the diagnosis, some uncertainty in the treatment plan, the outcomes, we have to be so careful in how we communicate that. This upcoming grand rounds will tie into it, and Dr. Eber will give us our keynote in April. So if you're interested on this agenda and this conference, all the information is on our website, cmda.us. And the other announcements that I had were just related to our national association. Tonight at 5:30 p.m., PALT Med is hosting a candidates virtual town hall. You can log on and meet the candidates running for national office. And in March, the national conference in Anaheim, California will take place March 26th to 28th. And we will have a Colorado special reception for people from our state. So hope to see you there. Thank you so much for joining today. Oh, yes, Dr. LaRocca, thank you for asking about the grand rounds. I will definitely put that information out by email, and I can put it on, see the link, see if I can stick that in the chat box real quick for you. Thank you for asking. Any other questions? Good to see everyone. Hope you enjoy the rest of your day. Thanks for joining our monthly meeting.